Okay, let's start. Of course, people can still join during the presentation. Welcome everyone to this community talk of October. This edition is titled TechnoRehabLab, Transforming Osteoarthritis Care with Technology in Burundi. We would like to welcome Mr. Jean Mapinduzi of the Institut National de la Santé Publique in Bujumbura, Burundi, and also Professor Bruno Bonnecher of the University of Hasselt in Belgium. Allow me to make three practical announcements. First of all, throughout the presentation, you can raise your questions in the chat. We'll make sure to cover them during the Q&A. Also, during the presentation, please mute yourself. However, during the Q&A, you can unmute yourself, put on your camera, and address your question directly to the presenters. And finally, be aware that this community talk is being recorded. We do this so that we can share it afterwards on our website and on our YouTube channel. Voilà, so those were the practical announcements. So without further ado, let's dig in. We hope you enjoy the community talk.
Okay, thank you very much, Laura, for the introduction. And of course, thanks to Vleer to inviting us to present this really interesting project that we have been working on for the last year. And we still have one more year as this in a short initiative project. So I'm here with my colleagues, Jean. So we are happy to be able to do it here in Belgium because it will be much easier. So yeah, we have already been introduced, but it's just a small reminder. So
good morning, everyone. My name is Jean Mapinduzi. I'm a physiotherapist with a master's degree in orthopedic manual therapy, and I'm a lecturer at the Institut National de Santé Publique, INSP, Bujumbura, Burundi. I am involved in both clinical and research activities and coordinating the TechnoRehabLab² project at the INSP. Thank you, Bruno.
Yeah, so I'm Bruno. My background is also clinicians, but I then do my PhD in biomedical science and engineering, so more about the technology. I also have a master in epidemiology and public health, which is really important for the implementation of the care. And as mentioned, I'm currently assistant professor at the Faculty of Rehabilitation Science of the University of Hasselt, where my main interest is in technology-supported rehabilitation. So now a really important first question is why this project is important. Actually, the first really important thing is because people tend to forget that, especially in high-income countries, but actually access to good healthcare services and with basic healthcare services, it's really a human right. So it's in the constitutions, and therefore all people, wherever they live, should be entitled to the same collective efforts that can protect or improve their health. And of course, access to healthcare, it's include rehabilitation services. But although we know that it's a human right and that we have a lot of different models that have been developed to try to further implement healthcare services across the world, we know that unfortunately, in most of the cases, it's not the case. And we will first discuss a bit some numbers, and then we will define what is rehabilitation, and then we will discuss our project more in depth. So it's always important to see that we have been seeing a new paradigm in health. So changing from a young population in Africa, which is still the case. You see that the median age is 18 years old, so indicating that 50% of the population is still younger than 18. In comparison, in Europe, you can see that it's 42. So of course, you have a huge difference. But what we tend to forget is that despite the fact that this population is still relatively young, so approximately we have 5 to 6% of the population in Africa that is age 60 plus. But if we look at the predictions for 2050, it will be approximately 10% of the population. And those are relative numbers. But if we look at the absolute numbers, we can see that we are always discussing of the challenge of the aging population in Europe and in the States, but actually this part of the population is still relatively limited. But if you see in 2050, the projections for the number of people aged 60 plus in low and middle income countries, actually you can see that this will be the huge part of this population in those countries and not only in our, let's say, high income countries. And what is also striking to note is that this increase in the population age 60 plus will really severely affect the poorest country in the world, as you see, with the one with the lowest gross national income. And you can see that the increase in those aging populations will really severely affect them with only a very few limited resources allocated to healthcare. So they will have to face this huge challenge of an aging populations. And in terms of care, of course, we know that we have a shift from acute disorders that are still the most incident and prevalence disorders in most of the low-income countries with, for example, malaria, tuberculosis, and so on. But with this aging population, we have a shift from acute disorders to chronic disorders, what we also called non-communicable disorders. And actually, if we look at those disorders, we have, for cancer, cardiovascular diseases, but we also have osteoarthritis that is really associated with the aging. And if we think in terms of rehabilitation, this shift from acute to chronic illness, it's something that is also really important, because in the acute phase, the role of rehabilitation may be a bit less important, but in the chronic phase, that's something that is really important, because by definitions, those chronic disorders, the patients, they will never heal from those. So they have to learn to live with their disease or with their disabilities. And that's really the role of the rehabilitations, will be to improve, to maximize their functions despite this disability or this handicap. And in this project, we will specifically focus on osteoarthritis, because that's one of the most incident and prevalent disorder that is associated with age. You can see that we really have this linear increase in the incidence, so the number of new cases per year associated with aging. But Jean will discuss more in details about the clinical implication of this pathology for the populations. We have been already discussing a bit about rehabilitation, but it's good to define exactly what is rehabilitation, because you may not be fully aware of this. So basically, rehabilitation is a process that encompasses a wide array of intervention. So it's not linked to one single intervention. It's really multidimensional. And the aim of rehabilitation is really to enable the individuals with health conditions to optimize their functioning, reduce disability, and increase participation in society. So we can see here the link with the definition of health from WHO, that is not only the absence of disease, but it's also the full participation of the individual in society. So functioning, participation, and reduced disability. And the ultimate aim of rehabilitation is to improve quality of life of all patients. The need for rehabilitation is something that is really huge. They've been nicely summarized in this paper. You can see the prevalence of the need for rehabilitation services back in 1990, according to the age group. And if we see the numbers 30 years later, you can see that the need has doubled. So there is something that is really important, rehabilitation services, and now WHO recognized this, the importance of rehabilitation services. They've been launching last year this World Rehabilitation Alliance, really to advocate for rehabilitation. And WHO, they estimate that across the world, 2.3 billion of people could benefit from rehabilitation services. So it's 1 out of 3 people living in the world. So the need is really huge for rehabilitation services. But unfortunately, we know that we have to provide those rehabilitation services with really limited resources, not only financial resources, but also human resources. This is a map showing the size of the country proportional to the number of healthcare professionals per inhabitants. And it's always so striking to see that here in Western and Central Africa, we can barely not see those countries. So we have a huge shortage of healthcare professionals in those countries. And it's the same if we look at the physiotherapist. Of course, rehabilitation is not only related to physiotherapists, but here for the sake of this presentation, we will limit ourselves to physio. And you can see here really low number of physiotherapists in those countries. And as I already mentioned, the World Rehabilitation Alliance tried to improve the situation, and we are quite proud and happy, both Jean and me, to be part of those World Rehabilitation with the University of Hasselt and with the Institut National de la Santé Publique in Burundi, Bujumbura. So basically, if we have to summarize the problems related to the development and the implementation of rehabilitation in Africa or in other low and mid-income countries, we have three main issues. The first one is the lack of clinicians. We've shown the maps. Second one is the lack of infrastructure, because even though we have enough clinicians, we need to offer them a good infrastructure to provide their services. And also we have a lack of evidence about how can we really implement rehabilitation in those countries, but we will see that in a moment. So our aim and our vision is, of course, ultimately to improve not only the quality, but also the quantity of rehabilitation services we can provide to our patients in different contexts. And to do so, we have to work on three different aspects, as we've seen those potential limitations at the moment. So the first and probably most important point is, of course, the education, because education should really be the first step, because we know that education is one of the most important things. We need to have more healthcare professionals working in rehabilitation in those countries. Different type of training can be provided. Of course, we can teach the teachers that will later on teach the clinicians in the country. We have to develop more bachelor programs to really train and educate physio. And then later on, we have to develop some specialized program. They have to train in neurorehabilitation, in musculoskeletal disorders, and so on. But what is also really important related to education is the health literacy. It's not only important to train more physio, but it's also important to raise awareness about rehabilitation in the other healthcare professional, but also in the population. Because if the populations do not understand why rehabilitation is important, they will not come to the rehabilitation services. So the question is it enough to develop more school, more training program? Of course, it's really important, but unfortunately, the problem is so huge, the need for rehabilitation is so important that it will not solve this lack of clinicians. So we have to be a bit more innovative and think about other solutions. And one really nice solution is task shifting. It has been proposed by WHO. So basically, task shifting is the fact of delegating some tasks that are usually being done by healthcare professionals to other people that are maybe less trained, less educated. And so in our case, we will try to delegate some rehabilitation services to maybe the family, maybe the relatives of the patient, or other community-based people working in those countries. And in rehabilitation, we have this concept of community-based rehabilitation that is really important. And that's, as I already mentioned, it's really this strategy within the community to develop more rehabilitation services and to turn the relatives and family, friends more active in the rehabilitation of their relatives. But if we look at the community-based rehabilitation matrices, the first thing is that it's not only related to health, but it's also about education, empowerment, and so on. But if we look about rehabilitation and assistive technology, we see that it's something that is within this community-based rehab, of course. But what is interesting is that we have those assistive devices. And that's something that we know quite well here in high-income countries, that we can use a lot of different types of technologies, ranging from really expensive technology to really affordable technologies to help to provide more rehabilitation services. And so we think that maybe the experience that we gain here in this TechnoRehabLab that we have been developing at the University of Hasselt, where we try to demonstrate and to use and to implement a lot of different technology. We say that maybe we can use some of those technology to provide more rehabilitation services in regions where we have those shortage of healthcare professionals. And one of the most promising technology that we can use in the context of low-income countries is mobile health. So basically, mobile health, it's a component of electronical health. So electronical health is the use of any types of informatics within the healthcare. And mobile health, to keep it simple, is all the applications that you can use on smartphone or tablets to provide some types of healthcare services. It can be relatively simple. It can be a simple calendars with some reminders about your medical appointments. It can be a calendars with a list of exercises that you have to do. It can be linked with activity tracker, but it can also include some exercises that the patient has to do. Also, something really important that we have seen a lot during COVID-19 pandemic is that it can be used to communicate, not only to ease the communications between healthcare professional and the patients, but it can also be used to create a community of patients where they can share their knowledge and experience with the disease. That is something really important. And also something really important is that it can be used to provide more information about the diseases, because we also know that the more the patient know about their conditions, the more they know about rehabilitation, the more adherence they will be to the treatment. Is it working in rehabilitation, the use of mobile health? Actually, it is. We have now a lot of systematic review, meta-analysis that have been done. So meta-analysis, it's the combination of different individual study, and then we put all the results together, and based on those results, we can define the level of evidence associated with this. And we have a lot of different systematic reviews being performed in a lot of different pathologies and things. But in our context, the question is not only is mobile health or is technology supported rehabilitation working? Our question is to know if it's working in Africa, because of course the context is quite different. And actually, we did this study a couple of years ago, and we see that although on the paper, mobile health is something that is really interesting to implement in low and mid-income countries. But if you really look at the number of studies being performed in those countries, you can see that it's still mostly in high-income countries, and we don't have a lot of evidence in low and mid-income countries. So this leads us to our second point. If we want to improve rehabilitation services, we've seen we have to improve educations, but the second really important point is that we have to develop and to improve local research in rehabilitation, really in low and mid-income countries. Actually, we have been trying to do that for years, but now with the development of this center, we can really develop and build local expertise in research, because as I mentioned earlier, the problems in research, not only in rehabilitation, but most of the other domains, is that the guidelines that has been developed, they've been developed based on studies performed in high-income countries. And so we are really lacking local evidences about the acceptability of new treatment, of new intervention. And based on this, we have to define whether or not we have to do some changes in the way we are integrating with our patients. And only when this cultural validation has been performed, we can perform really validation study to determine the level of evidence. And then we can try to think about how to integrate this technology within the current infrastructure. And only by doing this, we can really improve ultimately the care for our patients. So that was a general overview of introduction. I will give the floor to Jean, that will really present more in details the project that we have been running in Burundi.
Thank you, Professor Bruno, for the floor. And to develop the local evidence, we have to make a literature review to see what is internationally validated and implemented. And so we conducted a systematic review and a meta-analysis to evaluate and identify the different technology that are used in patients with non-specific spinal disorders, and to evaluate their efficacy and their implementation or applicability in the context of low and middle-income countries. The results showed that this technology can be effective and can be implemented in low and middle-income countries, but we have to make some adaptation for this in terms of language and in terms of internet coverage. But we still have challenges about price and geographical accessibility. In Burundi, due to the lack of evidence-based practice, we developed a technology rehabilitation research center to improve the management of hip and knee osteoarthritis in the context of low and middle income country as Burundi. Osteoarthritis is a disabling condition in geriatric population with various symptomatology, and this can lead to severe disability, and exercises have been found to be the first-line strategy to mitigate the progression of this condition. Exercises, whether supervised or home-based, can be considered as the first-line strategy to manage this condition. And the second strategy is medication and intraarticular injection before doing operative management. In Burundi, osteoarthritis is a major public health problem with a significant proportion in older population. This leads to severe disability, especially in its advanced stage. The standard line treatment is rehabilitation and exercises, along with the pharmacological and the total hip replacement. In Burundi, there is a need of development of contextually adapted supervised exercises programs, along with the contextually adapted technology-supported home-based exercises programs. This is to decrease pain intensity, mitigate disability, and improve quality of life. In Burundi, osteoarthritis is managed through pharmacological and passive physiotherapy treatments by medical doctors and physiotherapists. But there are very limited access to these services due to the lack of healthcare professionals, temporal, geographical, and financial limitation. Therefore, rehabilitation of osteoarthritis is delayed due to these mentioned factors, along with infrastructure and home-based exercises program, a lack of this infrastructure and home-based exercise programs. The aim of this project is to develop a technology rehabilitation lab, which will use technology to conduct research, support physiotherapists, and provide personalized rehabilitation to patients. Specifically, the project will also involve a comprehensive training program for rehabilitation care professionals, research to determine the local effectiveness of new interventions, and policy support from local ministries. This project will also collect data on the acceptance and the clinical efficacy of the new technology through questionnaires, focus group, and interviews. Our technology rehabilitation research center is integrated in a building of 3 levels. This building is in the INSP of Bujumbura and has been built on the finance of APF and the Wallonie Bruxelles International. And many thanks to this, to APF and Wallonie Bruxelles International for this nice building. At the first level, there is a physiotherapy and rehabilitation care service where patients with the different conditions indicated for rehabilitation can be received and treated. The second level is a school in physiotherapy and rehabilitation. And the third level is our technology rehabilitation lab, where we perform assessment of patients, and we perform also training of students from the School of Physio and Rehabilitation. This ensures we train these students on the new technologies, and this ensures to integrate this new technology in clinical practice. Rehabilitation is a process from assessment to intervention via goal settings, And after each intervention, we have to reassess. This will allow us to track the rehabilitation outcomes and readjust treatment. Objective of this lab is to perform multidimensional qualitative and quantitative assessment. And in quantitative assessment, we assess normally range of motion, strength, gait, some physical performance tests using new technologies. And the second objective is rehabilitation care and prevention. This is an example of an assessment session where assessing the strength of quadriceps. We perform also a cross-sectional qualitative assessment using questionnaires, interviews, and focus groups. We can also assess quantitatively some parameters such as range of motion using K move, strength using K push, and balance using plates. We perform also cross-sectional quantitative assessment to analyze the gait parameters using activity trackers or sensors. This will help also to track the working profile. We perform also continuous assessment where we give activity trackers to patients and they wear them at home for 1 week, and after this week, you can analyze the physical activity profiles such as vigorous, moderate, or light intensity. We use another activity tracker. This is a connected watch. This also gives some physical activity profiles on distance of steps, the duration of physical activity, the energy expenditure, the number of steps, and the inactivity alerts. In rehabilitation, we have also performed the two meta-analysis. One was to investigate the effects of supervised exercises compared to home-based exercises. This showed that supervised exercises are more effective than home-based exercises. Another meta-analysis was to investigate the effects of mobile health technology supported home-based exercises compared to supervised exercises, and they said the result showed that the two interventions may display equivalent effects. From these two meta-analyses, we can say that it is very important to develop in our country a contextually adapted supervised exercises along with mobile health support home-based exercises to, to improve the management of hip and knee osteoarthritis. For rehabilitation, we are going to use an open TechnoRehab. This is a product of Humanity and Inclusion. This open TechnoRehab has different exercises, and the patient have to perform these exercises depending on the part of the body that is suffering and the clinical condition. Some achievements have been made. We have already developed research programs and the methods, the meta-analysis, and now we are doing a multidimensional and multi-sensor assessment in patients with the hip and the knee osteoarthritis in Burundi. We performed many meetings with the community stakeholders to inform them about the importance of research in rehabilitation, and we discussed also about the future direction in rehabilitation. I've made some network and a partnership with with the Humanity and Inclusion, the APF, and the Wallonie-Bruxelles International. Research and education are the milestones for sustainable rehabilitation to improve the quality and the quantity of rehabilitation. To improve rehabilitation services in terms of quality and the quantity, we have to combine conventional rehabilitation and telerehabilitation, dealing with new paradigms in terms of mobile health technology, virtual reality, dual task, and the remote monitoring. I give the floor to Professor Bruno.
Okay, thank you, Jean, for this nice overview of the project and what has already been done. Now we are going to discuss a bit the challenges that we face, because yeah, obviously it's not always easy to try to implement some new intervention in the healthcare, but especially when it includes technologies. And so this is a picture of this bit crazy guy who ran from South Africa up to UK. So he crossed all the Africa, and I think it's a nice view that you may encounter some difficulties, but if you keep believing in yourself, you can achieve even crazy things. So here I will just present broadly the challenges from a more theoretical point of view, and then Jean will discuss more about the challenges that they face really within this project, so in Bujumbura and Burundi. So when we think implementing or developing a new intervention in the healthcare, actually it's people may think that it's only about the patient and the clinical levels, but actually it's, yeah, you have to think much broader and wider, otherwise it will never be successfully implemented. So you have to work at the different levels, the micro, the meso, and the macro levels. Again, we're not going to go into the details here, but it's important to be aware of those different levels with the different stakeholders at each and every different levels. And the really important thing is that you have to synchronize and coordinate your actions if you want a sustainable and successful program. And the good thing is that, again, WHO, they developed some nice guidelines and programs that can be used to try to maximize the chance of success of those different intervention and levels. And so we are trying to follow those strategies developed by WHO to be sure that we align with those objectives to maintain the sustainable actions in our project. And now I will give the floor again to Jean, that will discuss about the specific problems and challenges and how they successfully manage them in
Thank you, Professor
Burundi.
Bruno. At the three levels, as Professor Bruno has said, in Burundi, at the macro level, we have challenges on the delayed procedure to get official documents. For example, to open the account for this project has taken a long process. This started from the INSP to the Ministry of Health, and from the Ministry of Health to the Ministry of Finance, and from this to the Republic Bank. And this process has taken about around 3 months to get account. Another challenge is the lack of cohesive and integrated approach to health policy, planning, and delivery at all levels of the health system, especially in rehabilitation sectors that is somehow new in Burundi. There is also a lack of awareness of research in improving training and rehabilitation outcomes. At the meso level, there is a big gap between the new technology and the geriatric population. Geriatric population is an older population that is not used to new technologies. Another problem is that technology are internet dependent, whereas in Burundi, there is a lack of internet coverage. This technology must have a permanent charge, and in the context of low and middle income countries, there is a lack of power supply. We have a problem on the clinicians that are not trained on the synchronization of technology. And some technologies are not made to operate in the context of low and middle income countries. For example, the connected watch Garmin is not working in Burundi. We have also another problem about the technical troubleshooting capacity of these new technologies. At the clinician level, we lack education on available technologies, and there is a lack of awareness of the possibility and the limitation of technologies. There's also a lack of awareness of validations of new technologies in the context of low and middle income countries. We have a big challenge also, the discrepancy between the number of clinical researchers and the high prevalence of non-communicable disease. We have a few clinical researchers with a high number of chronic disease. At the micro level, we have a challenge between patient and these new technologies in terms of language barrier, culture. This may prevent patients to adhere to new technologies due to their different beliefs. And this population is an old generation, which is that is facing new technologies. And this population has also a problem of health and digital literacy. I can say that rehabilitation and technology forms a double challenge, and we have to work with flexibility and adaptability and creativity to overcome this challenge. To prevent from failure of this project, we have to identify and involve community stakeholders, and some small but significant steps can be undertaken. We have to make some patient education on technology rehabilitation. We have to combine conventional rehabilitation and technology-supported rehabilitation. We can also organize continuous training for rehabilitation professionals on technology, workshop to inform stakeholders and clinicians on new technologies. As the impact and the perspective, this project will enhance capacity building in musculoskeletal rehabilitation, especially in the rheumatology area, using mobile health technology to deliver exercise therapy. And the ultimate goal is to improve the quality and the quantity of rehabilitation of osteoarthritis condition. But the principles developed may also be applied to other patients groups with diverse conditions such as neck pain, low back pain, stroke, trauma, and so on. And this will help reach the rehabilitation objectives set by the World Health Organization. Result of this project will be communicated to the stakeholders, professional union, and patient associations for feedback group. As a conclusion, I can say that rehabilitation is a huge need with the limited offers, and mobile health and other affordable technologies are promising, with challenging in implementing rehabilitation, technology acceptance, and technical challenge also. To succeed in rehabilitation, we have to work in multi and interdisciplinary teams. I give the floor to Professor Bruno to continue with the conclusion.
Yeah, okay. Thank you, Jean, for this conclusion. Here, I'll just go back to the three main challenges related to successful implementation of rehabilitation services in low and mid-income countries. So we have seen that we have indeed a lack of clinicians, the lack of infrastructures, and the lack of local evidences. But I will take this opportunity to thank the VLIR not only for supporting this project in Burundi, but actually to support other projects and to help us to develop and to support our vision. Because if we think about the lack of clinicians, we've seen that, of course, education is something that is really important. And so we are really happy to have an ITP project that just started here in September. It will be based in Benin, but that will try to improve the level of education and really to teach the teacher in the sub-Saharan African region. They will come to Belgium for a 1 month intensive internships and then go back to their respective countries where they can share the knowledge they've gained. And we also have clinicians from those countries that will go to Benin to be trained in new technology and in the latest advance in rehabilitation. But the lack of infrastructures, we have been developing this research center in Burundi, but we also had previously short initiative project in Lubumbashi, where we have been developing also a TechnoRehabLab, where we are providing care for children with sickle cell disorders, to get stroke at very young age, and that they didn't have access to any rehabilitation services. So again, thanks to the VLIR, we've been able to develop this center that is now fully functional, so our patients get free rehabilitation services after stroke. And the lack of research, that was our third pillars, but again, thanks to the infrastructure we have been developing, not only the physical infrastructure, but also capacity building, we have been able to teach those healthcare professionals about the research, to raise awareness about local research, and therefore we have been able to really get some publication about the real evidences locally and with real results. And I think that's to conclude. I always like to quote this proverb that, of course, working and doing collaboration, it may sometimes you have the feeling that you are not really doing things and that it takes time to get there, but it's really something that it's true. Sometimes it's really some small steps, but at the end of the day, with multiple small steps will make a difference. And so thank you for your attention. And if you have questions, remark, or if you're interested in further collaboration with us, we'd be really happy to discuss with you. We have the email here, and we also have the website from the project that is presented in this. So thank you for your attention, and we would be happy to take some questions.
Thank you both for the really nice and insightful presentation. You're actually only halfway in the project, so it's really nice to see where you stand already today. There were no questions raised in the chat, so I invite everyone to unmute yourself and to ask your questions directly to the presenters. Maybe if I can start to break the ice, I had some question, like in the end you said you have related projects in other countries. So you have an ITP running in Benin or based in Benin for other countries to participate, and also a center in Lubumbashi. Can you maybe share the common challenges that you see in the different parts of the continent, of the African continent, and maybe also challenges that you see particularly in Burundi that maybe don't occur in Benin or Lubumbashi, or maybe things that go quite smooth in Burundi compared to other countries?
Yeah, I think that, as Jean mentioned, really the challenges in all the countries where we are currently collaborating. It's really this. It's not only about trying to implement new technology in the rehabilitation, but the first step is really to develop and implement rehabilitation in those countries. In countries, yeah, with limited resources that we know, but with such a low level of awareness about rehabilitation, that's the first step. It's really to convince people, clinicians, stakeholders, politicians, and so on, that rehabilitation is indeed very much needed. So that's the first step. And then the second step is also to convince them that, yeah, the technology that we are using, it's not only gadget, but that you can really do some relevance and that you can do things that may have an impact on this population with, for example, a smartphone or a smartwatches or something like this. So it's really this double challenges. It's not only about implementing rehabilitation, but implementing technology within this rehabilitation. So it may be seen as a challenge because it is indeed a huge challenges. But on the other hand, since there is currently not much rehabilitation services, you can also use technology directly to implement rehabilitation. And because that's also something we observed in Belgium or in high-income countries, because the rehabilitation is already well developed. And so people, they may also be reluctant to use new technology because they say, yeah, we have always been doing this like this, it's working quite well, so we don't need this technology. So starting from not only from scratch, but from a low level, it can be also an opportunity to directly integrate that also, as Jean mentioned. So now we have this center with technology and we try to directly implement that in the curriculum of the bachelor students there. So directly they will face this technology and they will see what are the possibilities and so on, and so they can directly start working with their patients. So that was for the first point. And for the second point, what is more challenging in Burundi? Actually, it's not more challenging because from my experience, that's the country where it is the easiest to work because we have this nice infrastructure. We already mentioned this school of physiotherapy that is still supported by APFE. So this thing is working quite well. We also have this clinical center that has been open 1 year ago or something like this. And also what is really nice is then thanks to the huge effort of APFE, now rehabilitation services is really included in the National Healthcare Program of Health in Burundi within the physical medicine and rehabilitation plan. And also something that is really important is that within this guideline of those legislations, there is something about digital health and digital rehabilitation. And so, yeah, that's a really good opportunity. And we say that, yeah, we have the policymaker, but of course, having strong support for the high level with the Ministry of Health, for example, it's helping a lot. And also not having to build everything from the beginning, but to be incorporated in a existing good infrastructure, it will help also a lot. So yeah, because that's what we are facing in, for example, in Benin and also in Lubumbashi, because the development of rehabilitation there is not as advanced as in Burundi. So we don't have this strong infrastructure to support current, also hopefully future projects.
Yeah, interesting.
Also regarding to technology acceptance and internet coverage and so on, although we have some difficulties, but it's still quite good compared to what we've seen in Congo and even in Lubumbashi. So
interesting. Thank you for the answer. Meanwhile, there are 2 questions in the chat, but if okay by you, I would like to invite you to address your question directly. It's the best way to make sure that we understand the question fully. So can I invite Mr. Mohamed Tabous to open the mic? Otherwise, I can ask the question and read it out loud. So the question is, do you think that initiating regenerative medicine and cell therapy in Africa would be a great step for a real solution to osteoarthritis? In your experience, would you think that that could be part of the solution?
I can say that in Burundi, for example, using, for example, medicine or some cell therapy, I can't not say that it is not a solution, but it is not initiated in the context of Burundi. So patients are taking medication for a long time, and this is may have some adverse event as it is a chronic condition. Reading some literature and new evidence to say that being physically active and doing some physical exercises can help enough than taking this medicine for a long time.
yeah, and also what we observe that may significantly affect this is that Yeah, in those countries, the patients that we are seeing, they come quite late already in the process because they think it's normal to have a bit of pain in the knee or in the hip when you're walking a lot. So they will come and consult at quite late stage where of course the damage are already well in place. So maybe it will be too late. So that's also why we are insisting a lot about information, health literacy, and try to really raise awareness. If you have, for example, in your 50s and you start having pain on your knee when you're walking a bit, yeah, you should consult early, and that would be also our target for those supervised exercises and that are better suited for the prevention, at least in the early phases, because otherwise if the cartilage and the joints are already too many damage, yeah, even with stem cell of hyaluronic acid, it will not be effective enough.
I can speak. You hear me?
Yeah.
Yeah, sorry, I was in the lab. So technically, I am a PhD student in Kaidlada and with the Prometheus team, and we're working with the tissue engineering and the implant, 3D implant, like base and stem cells and HPDCs. So the idea, yes, sure, but it's real. But now in Belgium, we can make an implant, and it's something it's usual. That's first. Secondly, like when we're speaking about stem cells, is about it's not just about the first step that we can make in spheroids, organoids, and this organoids can use it for a different step in making bones. So the question is, if we're making the spark, if we initiate something like that in Africa, that will be a good initiative, because when we're speaking about that, we're speaking about personal medicine, attempts, like bringing other solution for cancer. It's something we don't have in Africa. So initiating something like that in Africa would be a good idea, or just imagination and crazy stuff. Does it make sense?
Yeah, I think it's of course it's a good idea, but you have to see if it's doable or not, because I mentioned this early identification of patient. It's really something that is really important, but that's also something we want to further develop with this, for example, gait assessments, balance assessments, because our aim is also to identify patients with higher risk, for example, that could be good candidate for early intervention or more preventive treatments. But then, yeah, the second problem is always the same, is the price, but not only the price, also the you need to build and to develop specific infrastructures. You need to keep them cold, safe, and so on, which is not always possible because when you have this power output, this cut in electricity and so on. So yeah, that's a problem, because that's also here in Europe or high-income countries. Of course, the gold standard is to put prosthesis, but that's not possible in Burundi because of the high cost. So
yeah, sure. If you say something like that, we're lower decreasing the cost of this kind of product, because if this product is just limited in the manufacture of this kind of product is limited in Europe, that's always will be high cost compared to Africa. If we initiate something like that, maybe in the few years, we will decrease the price, and other country with low income can have access to this kind of technology. Is the idea. It's like what happened with COVID-19. Like, you know, the European and the advanced country have the ability for manufacturing vaccines, and Africa can't do that. Then the initiative for GAVA begin, and the African country try to do something in initiative. So technically, the idea is what we should waiting for something like COVID for beginning something good, or we can do it from now.
Yeah, in an ideal world, of course, you can do it, but we know that the big pharma companies are still very much interested only in high-income countries and not, unfortunately, in those countries. And we didn't cite some numbers about Burundi, but it's still one of the poorest country in the world. So that's also making it more challenging to access to those drugs. So that's why we really think and believe that early treatment and preventions and doing those kind of exercises that could be really time and cost efficient should really be the first line of treatment. And actually, that's also here the case in high-income countries. First, it's about prevention and exercises before going to phase 2, where you have those drugs and those intervention.
Thank you. Thank you.
Yeah, thank you very much for your question and also for sharing your from your expertise, Mohammed. I see we have 3 minutes left, so I would like to give last person a chance to ask a question, if there is any.
Yeah, there were another question, but it's also related to drugs, so I guess it's a bit the same type of.
Yeah, I think so, indeed.
Yeah, because as Jean mentioned, the second line of treatment is indeed AENS and or injections, but even that, the patient, they don't always have access to those medication, or at least not continuously. So they may take for 1 month and then they don't have the budget available for the next, so it's not super efficient at the moment. So.
Well, maybe still there's room. Can I maybe ask a last question? Can you maybe touch upon briefly on the collaboration with APEFE? So how? So I understand you collaborated with them mainly by using their infrastructure. Is that correct? Can you maybe say how you reach out to them? Did you find a common agenda right away? What is the added value to work with another actor in this project?
Thanks so much for this question. The collaboration or the partnership with the APEFE is, but not is before this project. Before this project, APEFE has sent student to study, student in physiotherapy to study to Benin, and after then, this student came back to Burundi. They have been integrated in clinical services, and meanwhile, APEFE was constructing this building for rehabilitation school and rehabilitation care services. And as this project must be integrated in this new building, we had to have some guidance from APEFE, who is experienced in the domain of rehabilitation, and it gives us some idea about the technology, some kind of technology we can buy. How can I say also? Yeah, and there are some technologies that have already been bought by APEFE.
Yeah, and also what is important is this direct connections through the responsible, Olivier Jardin, with the ministry, and for the implementation of this national program in physical medicine and rehabilitation. So we are sure that that our objectives are well aligned with the national guidelines.
Okay, that's interesting, because of course that's something we always try to emphasize, and if we see good examples of complementarity and synergy with other actors like APEFE, or reaching out to ministries which can help to execute your project, that's always nice to hear, and might use that as a lesson learned for other projects that face maybe similar or that are active in the same field.
Yeah, sorry. And also, if you want to scale up this particular project and with some type of technology that we know are working quite well, because when APEFE starts 7 or 8 years ago there were only a very limited number of rehabilitation centers in the country, but now they're still investing, and now at the moment it's like 43 or 44
45
rehabilitation. 45 rehabilitation. So we can say that it's because we have those connections. If we say, okay, this program is working quite well, so we can easily implement that and really scale up at least at the country level. So that's also something interesting. It's really a huge network now that is being developed, and that So we can, it's being used for the students, for the internships and so on, but so we can also think to share your expertise gain in the lab to fertilize them.
Okay, yeah, very, very interesting, and I think very nice to end the presentation on that note, knowing that you're already looking forward how to have a scale up of your project, because it's always good to think about it throughout the process and not only at the very end. I saw there were no more questions, so on that note, we can end this presentation. But as you all know, we will share this presentation, and then you can also see the contact information in their presentation. So feel free to reach out to them if you have more questions now or in the future. And then that leaves me to thank you all for attending this community talk. Thank you for your attention and your participation. We always believe it's beneficial to share experience and insights, so thank you for that. And of course, special thanks to the speaker, Jean Mapinduzi and Bruno Bonnecher for this very insightful presentation and discussion. Congratulations already with the accomplishments, and we look forward to the continuation of your project and collaboration. And finally, we would also like to welcome you already for the next community talk that will take place on November 27th. The talk will be on a project called Upscaling Mass Rearing of Edible Grasshoppers and Cricket Species for improving food security in the northern Uganda. So a very different topic, a collaboration between researchers of Kulu University in Uganda and Thomas More. So very welcome to join next month. Stay tuned, check out our website, social media platforms, and stay up to date. Have a lovely day, everyone, and hope to see you next month. Goodbye.
Thank you for inviting us, and have a nice afternoon. Bye.
Thank you all. Nice afternoon.